Okay. So, good evening, everybody. Today we are going to focus about a very, very important topic, that is with regards to the hyponatremia. So this is part of a postgraduate lecture series, and hyponatremia is one of the common endocrine emergencies which is encountered in pediatric practice. And this is one of those conditions which is quite important in terms of the overall clinical perspective and in terms of challenges in terms of diagnosis and management. So what we are going to do overall is to have an overview about what really controls the sodium levels, what really controls the overall fluid status, and how hyponatremia happens. Then Dr. Pratik will talk about the etiology aspect of it, the various causes of hyponatremia. Then I'll focus about the approach and evaluation and management of hyponatremia. And finally, we'll carry it forward with regards to the Q&A session which Dr. Manoj will be doing. So Dr. Pratik and Dr. Manoj are with us. Dr. Pratik is a consultant in pediatric endocrinology at Regency Center for Diabetes, Endocrinology and Research. So Dr. Pratik, your views about hyponatremia as a condition overall?
So it is one of the most common electrolyte imbalances which we see. They might come to the OPD simply, or we might see them in the ICU. The diagnosis is tricky, but how we treat it is very important.
So that will be the key aim, to make the right diagnosis and the right treatment. And Dr. Manoj, fellow in our pediatric endocrinology department. Dr. Manoj, your opinion, views about hyponatremia and how it challenges and makes life a bit difficult for many of us?
Your voice is lagging, sir.
Now, what is your experience about hyponatremia?
Sir, as the PG exam going, means I have very difficulty in the management part per se.
So we'll try to focus more on practical aspects with regards to that and how we make it easy. Plus, we'll go on the exam part. So Manoj has cleared all the questions on hyponatremia, and we'll discuss from there in that perspective. So now I'll start off the presentation. I'll request the non-speakers to keep them on the mute so that there is no echo on that, and we'll start the talk and the deliberation directly from that perspective. So hyponatremia, as everybody has discussed, is a very, very important condition, and there are a lot of problems and confusion. And we'll start off with two cases which highlight how this confusion comes and how their problems occur. This was a 14-year-old boy who presented with drowsiness, was clinically euvolemic, had a high urinary sodium and a high urinary osmolarity. So we had a child who had a dilute blood and a concentrated urine, and clinically was euvolemic. So this is a classical feature of SIADH, was advised fluid restriction in the term of diagnosis of SIADH. But unfortunately, the child had a sudden worsening in seizures which developed. Now, this is a very, very common mistake which we encounter in pediatric endocrine practice, is that any euvolemic hyponatremia is often considered as SIADH and advised food restriction. When we'll discuss subsequently that SIADH is essentially a diagnosis of exclusion, and we have to exclude FT4 and cortisol deficiency before we label somebody as SIADH. Now, when the endocrine team was called here, we found that this child actually had a very low level of thyroid, and cortisol turned out to be a multiple pituitary hormone deficiency. So this is one condition which clearly illustrates that there is a need for comprehensive evaluation before we make a particular diagnosis in that setting, in that regards. We had the 16-year-old girl with abdominal pain who had recurrent episodes of pain and again developed seizures during admission. This time she had hyponatremia, was euvolemic, and was clinically fitting into SIADH. So this was pretty clear that this is SIADH, but your diagnosis does not end there. You have to look at a cause. So this child had been managed as SIADH on a couple of occasions, but this time when we were called, we were able to identify that there was a common feature of a recurrent abdominal pain in that girl, and that led to the diagnosis of essentially of porphyria, and that was causing the SIADH. So there is challenges which are there with regards to the evaluation as well as the management in that perspective, and we need to be very careful about in that regards. Now, if we go carry forward from here, so this is the PG lecture series that we are continuing. This is the 6th talk in the series, and today we will talk about hyponatremia, starting from pathophysiology, criteria, management, and then we'll finally take question and answers in that perspective. So all of you can go and have a look at our website, learning.growthsociety.in, which covers a wide variety of aspects of pediatric endocrine resources, provides opportunity to learn. There is also a YouTube channel, which this is being streamed right now, and you can have access to a large number of videos which are available on various aspects of pediatric endocrinology. Our courses, which provide validated tools for pediatric endocrinology learning and practical assessment in that regards. And then we have got courses like fellowship course and the postgraduate course, which is available for access in that setting. We do conduct 3 different types of grant rounds. One is that for the endocrine trainees, one for the general pediatricians, and this the PG lecture series in which we have covered growth, and now we are moving towards electrolytes in that regard. This happened once a month in that scenario. We have got publications which cover the entirety of pediatric endocrinology from basic to advanced, and our mobile application helps to diagnose and assess and manage these conditions. And we are going to launch today, as I speak, the next version of mobile app, which will provide much easier interpretation of a wide variety of conditions. We'll discuss about that a bit later. Now, hyponatremia, as we have discussed, is a very challenging condition, a condition which is associated with significant effects, acute effects, and long-term effects. So an understanding of pathophysiology becomes extremely important before we discuss about etiology and approach in that perspective. So when we talk about hyponatremia, why is sodium so important? So normally we talk about osmoles, and we talk about 3 major osmoles: sodium, glucose, and urea. Now, what we need to understand that out of these, sodium and glucose cannot cross the cell membrane. Urea can freely cross the cell membrane. So while from a osmolar, a primary biochemical perspective, all 3 are osmoles, sodium and glucose are the ones which decide the tone of the blood. So they are the major determinant of the tone of the plasma. In out of it, since glucose is normal unless somebody has hyperglycemia, sodium is the key determinant of the tone, and this decides whether the fluid comes in or goes out from the cells, and therefore sodium is very, very important. Even mildest changes in sodium will cause cell swelling or will cause cell shrinkage, and that is why sodium is one of the most tightly regulated, and I would say the most tightly regulated overall metabolite across board. If you talk about glucose, if you talk about calcium, they have a margin of error of around 10 to 20%. Sodium and osmolality have a margin of error of 1%. So if your serum sodium goes above 145, the body immediately starts to act. And that's why we need to know a lot about sodium and why it becomes important. Now, AVP is a predominant regulator as far as volume. And when I talk about serum sodium, we need to understand that serum sodium is determined by 2 major factors: the total amount of sodium and the volume. So the volume is the major determinant of sodium in that regards. And if your fluid is less or more, you will have hypernatremia or hyponatremia. Now, conditions associated with increased level of AVP, you will have decreased tone in the blood, and therefore the fluid will basically go into the cells because it's got more concentration. The cells will swell up, and that will cause features of irritability, headache, vomiting, those perspective, and ultimately they will try to extrude the osmoles, and that's why they will try to maintain it. Now, when we give them a particular treatment and there is a rapid change in sodium, there would be a sudden shrinkage resulting in myelolysis. So hyponatremia presents with cell swelling, and acute treatment will cause sudden disruption of the cells, causing myelolysis, and we need to be very cautious in that perspective. Now, this is what I was talking about. There are 2 major determinants of the overall sodium status: the tonicity, how much sodium you have, and the volume. Now, the major determinant of serum sodium is actually volume. And when we are looking of causes of hyponatremia, which are focusing today, we are mainly talking about problems which are associated with increased free water, rather than a problem of loss of sodium. And when we talk about in the next session about hyponatremia, that is again because of deficiency of free water rather than sodium excess. So most sodium disorders are problems of fluid volume status and rather than a sodium status in that perspective. Now we all know there are two mechanisms which maintain the volume. One is the thirst, how much water we take, and this is a major defense against hypernatremia. So if you're developing hypernatremia, you will drink more water and compensate. The other is urine output. So urine output is a major defense against hyponatremia. So if somebody is having lot of free fluid, there will be an impairment of the AVP effect and you will have aquaresis in that perspective. So urine output is the major defense against hyponatremia. And in a corollary, if you think of it, decreased urine output or increased urinary concentration, which is inappropriate for sodium level, quote unquote SIADH, is associated with hyponatremia. Now, what we need to understand is that ultimately, if we talk about chronic hyponatremia, anybody who has a chronic hyponatremia should have a AVP excess. And that is very, very important to understand in that perspective. So as we discussed, if your tonicity increase, the brain finds a signal that, okay, we need to shed the amount of that. We need to basically have more water. Your AVP starts coming in, and that really starts to really conserve the free water in that perspective. Now, if your volume goes down, now major regulator of volume is actually sodium. Now, this is also interesting. So when your volume status is not to do with free water, but with sodium. So if your volume goes down, the renin, angiotensin, aldosterone system starts to get activated. And what it does basically is that it is conserving sodium. But while it is conserving sodium, it is causing a loss of potassium. So conditions associated with defects in the renin, angiotensin, aldosterone system, be it hyporeninism, aldosterone deficiency, pseudohypoaldosteronism, all these conditions will be associated with fall in sodium, but a gain in proton and potassium because that's how your exchange happens. So they present with hyponatremia, hyperkalemia, and metabolic acidosis in that regards. Now, if your volume becomes too much, there is a third player which will come up in the picture, which is the atrial natriuretic peptide, which will cause loss of sodium. Now, this is very important in the setting of a SIADH state. So, syndrome of inappropriate AVP secretion is essentially a hypervolemic state. Now, because of that, the ANP becomes active and it causes loss of sodium. Therefore, the volume then becomes euvolemic and your sodium levels go down. So the cause of hyponatremia in SIADH is not only dilutional, it's actually sodium loss. What does it mean? It means that if you push them normal saline, you will cause immediate natriuresis because ANP is there, aldosterone levels are low, the body wants to shed all the sodium. So giving sodium chloride will be of limited role in that perspective. And that is something which is very, very important from that regards. So what we need to understand from this perspective is that the major cause of sodium imbalances are actually problems of water and not sodium. If you have too much water, you will have hyponatremia. If you have too little water, you will have hypernatremia. Absolute losses of sodium are rare. They may happen like gastrointestinal loss, very, very rare, or urinary loss in the form of diuretics, in the form of salt wasting crisis. But even there is an increase in AVP. Because all of these conditions cause hypovolemia, and your AVP also is triggered by a hypovolemia, and that really causes a further worsening of hyponatremia. So for anybody to have persistent hyponatremia, your AVP excess is important. This may be inappropriate in the setting of SIADH or appropriate in the setting of hypovolemia because of third space loss, because of adrenal insufficiency, diuretic use, or whatever in that regards. Similarly, and we'll talk about potassium later on, to have persistent hypokalemia, you need to have high aldosterone, which may be primary or secondary. So anybody who has a chronic hyponatremia, AVP has to be high. Anybody with chronic hypokalemia, aldosterone will always be high. Both of them can be appropriate or inappropriate. That's a different thing altogether in that regards. Now, more sodium that is filtered via the proximal tubule is absorbed right there, around 97%. And only 2% is basically absorbed at the collecting duct. But this is what is most important. This is the hormonally regulated sodium absorption. This is done via the epithelial sodium chloride channel, which exchanges sodium along with chloride. Now, this is where aldosterone acts. So all that we're talking about today is largely at this point, 2%, 97% is already absorbed here. Now, this epithelial sodium chloride channel will cause movement of sodium and chloride. And you will say, okay, this is a neutral compound. So why should they will be exchanged with potassium? The reason for that is sodium is brisk. It goes off just like that, while chloride comes out slowly. So the lumen, the tubular lumen becomes electronegative. And because of that, it then attracts positive compounds like proton, potassium, magnesium, calcium. These will be less, but proton and potassium are most important. So therefore, anybody who has hyponatremia, anybody who has got a decreased effect of aldosterone action, anybody who has got less delivery of sodium in this region will not have enough sodium to exchange with potassium and proton. So whenever you have a RAST effect, you will have hyponatremia. Along with that, you will have potassium retention causing hyperkalemia and proton retention causing metabolic acidosis. So that's the classical picture of RAST effect. Now, the whole pathway which regulates this is the renin-angiotensin-aldosterone pathway. Renin is triggered via potassium excess and volume depletion. It then converts angiotensinogen to angiotensin 1, which is converted via the peripherally via the angiotensin converting enzyme to the angiotensin 2, which is very, very important in regulating both sodium and volume. Now, AN2 is going to have a direct effect on the blood pressure by causing vasoconstriction. It is also going to stimulate thirst, and it is going to produce aldosterone more. So it is a very interesting phenomenon. Your volume goes less. Your body senses that you need to increase your pressure, you need to increase your volume, and you need to increase your sodium. So just by using angiotensin 2, it is causing vasoconstriction on one point, increasing thirst, so volume goes up, and increasing aldosterone, increasing your sodium content. So this is the wonder as far as the RAS axis. It from one aspect, it has a multitude of effects which are there in that perspective. Now, ACTH and vasopressin have some permissive effect on aldosterone secretion, but the major regulator of aldosterone is actually at the level of volume and the renin system and not ACTH. This is very, very relevant in, and this is what Dr. Pratik will talk about in the setting of central cortisol deficiency or ACTH deficiency. So in ACTH deficiency, you will have hyponatremia, but that hyponatremia will not be severe because you do not have a mineralocorticoid problem. Even if you have zero ACTH, the renin will control your aldosterone and your hyponatremia will not be severe. But if you have a combined glucocorticoid and mineralocorticoid deficiency, you will have severe hyponatremia. On the other hand, if you have an isolated defect of the aldosterone, you will have hyponatremia, but there is no concomitant cortisol deficiency. Remember that cortisol inhibits vasopressin. So if you have cortisol deficiency or AVP will go up further, you will have worsening of hyponatremia. So the worst condition associated with hyponatremia and hyperkalemia is primary adrenal insufficiency. Both cortisol as well as aldosterone is affected. If you have ACTH deficiency or ACTH resistance, you will only have hyponatremia. Your potassium will be normal and your sodium will be marginally deranged. So very importantly, you do not need to have hyperkalemia with hyponatremia to have adrenal insufficiency. That is true for primary adrenal insufficiency. In secondary adrenal insufficiency, you will just have hyponatremia. While the third picture of aldosterone deficiency or resistance will have severe hyperkalemia as a major feature, while hyponatremia will be milder, around 120, 125 in that perspective. Now, ANP, of course, will cause natriuresis. So in somebody whose volume is more, like free space loss, cardiac failure, nephrotic syndrome, cirrhosis, or you have SIADH, ANP will cause further sodium loss and you will have hyponatremia in that perspective. So importantly, cortisol has an effect also at the aldosterone receptor, which is more relevant from a different perspective and therapeutic perspective in that regards. Now, this is also very important. If you have too much free water, like in the setting of a third space collection or in the setting of SIADH, the AVP secretion will go down. It will allow the urine to pass the water. And that's what I said, that the major defense against hyponatremia is urine output. The major defense against hyponatremia is thirst. The major defense against hyponatremia is the urine output. So if your fluid is too much, pass it in the urine. That's why the AVP goes down. So normally anybody who has got excess free water should have a urinary sodium less than 25 or a urinary osmolality less than 100. If, however, your urinary osmolality is more than 100, this is inappropriate. Dilute blood and concentrated urine, this is SIADH. Concentrated blood and dilute urine, that is diabetes insipidus. That's something which is important to understand. So now if we look at hyponatremia, it can either be because of too much free water. This may be because of third space collection like cardiac failure, nephrotic syndrome, or chronic liver disease, because of SIADH. It may also be because of endocrine deficiency. Now, these conditions will have hypervolemia. Along with hypervolemia, they will have hemodilution. So the hemoglobin will go down. And very importantly, if your volume goes up, in that scenario, you will clearly have a decline in uric acid, because uric acid excretion is dependent upon the volume. If your volume is more, you will lose more uric acid and uric acid levels become less. If your volume is less, you will lose less uric acid and uric acid level will go up. So uric acid is the best marker of volume status. And if you are confused between a low volume state like cerebral salt wasting versus a high volume state like SIADH, do a uric acid. If uric acid is low, this will favor a fluid volume more, that is SIADH. If uric acid is high, this will favor more in the setting of a cerebral salt wasting. And we'll discuss this in more detail in that perspective. You can have sodium loss, but I said major cause is free water excess. Sodium loss can be because of RAS defect, renin deficiency, aldosterone resistance, or tubulopathies. Now, interestingly, RAS defect will be associated with hyponatremia and hyperkalemia. As we'll discuss subsequently, we'll understand that usually electrolytes go opposite. If your sodium is high, potassium goes low. If your sodium is low, potassium goes up. So that's typical of RAS defect. But if you have a diuretic use or a GI loss, you will have both hyponatremia and hypokalemia. So just to summarize etiology before Dr. Pratik takes over, hyponatremia can be because of excess free water, which is U or hypervolemic with low uric acid, or sodium loss, which is hypovolemic with high uric acid. Excess free water may be cardiac, liver, or renal disease. You will have edema. You can see very easily in that scenario. Urinary sodium will be low. So volume status is very important. You may have reduced loss because of SIADH. And remember, cortisol deficiency and hypothyroidism are differentials for excess reduced loss in that perspective. Sodium loss could be extrarenal due to diarrhea or cystic fibrosis. Urinary sodium will be low, or renal, in which it could be tubular abnormalities like diuretic and tubulopathy, or RAS defect, in which you have a combined defect. Tubulopathy and diuretic use will have hypokalemia. RAS defect will have hyperkalemia, high potassium in that regards. And your urinary sodium will be high both in SIADH and renal loss. So if you look at this grid, what you need to understand is that if you know about three things, basically, you know about the volume status, you know about the urinary sodium and the potassium level, you can very easily classify which is the cause of hyponatremia. And this is what I'll discuss subsequently in approach. I'll stop here and see if there are any questions, and then Dr. Pratik will take over with regards to the etiology in that perspective. So I think now, Dr. Pratik, you can carry forward from that regards. So Dr. Pratik is a consultant in pediatric adolescent endocrinology at Regency Center for Diabetes, Endocrinology and Research. We'll be taking questions at the end of session. So please, you can put your questions on there and we'll take it up later on. Yeah, Dr. Pratik. Dr. Pratik.
Yeah.
Carry forward.
Yes. So basically, 1 minute. So hyponatremia can be classified, and if the etiology can be told whether there is any excess of any extra water or the sodium is being lost from somewhere. So let's go to the excess free water. It can be due to overload conditions such as cardiac failure, liver failure, renal disease, where the body has water, but it perceives it as low water because there is decrease in effective circulating volume, or there is reduced loss such as SIDH, cortisol deficiency, and hypothyroidism. Where the body is actually losing sodium, it could be via the kidneys or extra renal. In the kidneys, it could be due to a tubular defect, due to drugs or actual tubulopathy, or an actual RAS defect where there is aldosterone deficiency. This deficiency may be combined or isolated aldosterone deficiency such as in PHA. Extra renal causes, the sodium is being lost by the skin such as cystic fibrosis or the GI tract and diarrhea. Now, as sir mentioned, just to reiterate, the sodium, urinary sodium is an extremely useful tool. Now, what it signifies, where the urinary sodium is low, that mentions that there is hypovolemia. That could be effective hypovolemia or actual hypovolemia. What is happening here? There is ADH secretion, but also aldosterone is being secreted to reduce the sodium from the urine. So there will be urinary sodium less than 25. But where there is actual euvolemia or urinary sodium might be high is actual SIDH or cortisol or hypothyroidism, or actual renal loss of sodium where urinary sodium is more than 25. So urinary sodium makes an extremely important investigation in these conditions. Uric acid also is an important condition to see whether hypovolemia is there. So low uric acid means there is enough volume, maybe euvolemia or hypovolemia. High uric acid means there is hypovolemia. Now coming to first gastrointestinal losses, this is the most common cause, and not just the loss, it is the replacement of fluid with hypotonic fluid which causes the loss. So what exactly is happening here? There are GI losses. So that GI losses causes the body to become hypovolemic. This hypovolemia causes high AVP release. Now we already have increased free water because AVP is being released. But if we add hypotonic fluid, there is an excess of free water which causes the sodium to crash suddenly. In these cases, again, urinary sodium is less because aldosterone is being secreted to reduce the urinary sodium loss. Again, coming to the other causes, if there's a decreased effective volume, it is very similar to that. High AVP is present, urinary sodium less than 25, and it worsens with hypotonic fluid. Yeah. Now coming to SIDH. What happens in the SIDH, the body is actually normovolemic. ADH should not be released, but there's an inappropriate release of ADH with normovolemia. So what happens here is basically now, so there is again high AVP under the setting of normovolemia. Now understand, because there is normovolemia, urinary sodium is not affected because aldosterone is not released so high. And again, because of normo or even hypervolemia, ANP is released, which increases urinary sodium to more than 25. And again, urinary osmolality is adequately increased at more than 100. So SIDH can be caused by various pathologies such as CNS pathology, tuberculosis, brain abscess, porphyria as the case mentioned. Pulmonary causes infection, the child is on ventilation, malignancies, various drugs. And a rare but important cause is the V2 receptor activation, that is the nephrogenic SID. Here the SIDH is present, but the increased activation of the receptor causes ADH-like activity, but the ADH levels might be low. Now coming to the endocrine deficiencies, any case, if you find features of SIDH-like picture, the first thing we should do is to rule out endocrine deficiencies, because the treatment here is not fluid restriction, but to treat the underlying cause. The picture will be very similar to SIDH. There is decrease in free water excretion, but most importantly, ACTH decrease will not cause potassium because the RAS axis is not touched. FT4 has no connection with potassium, so potassium will be normal. Urinary sodium will be high, and fluid restriction is dangerous in these cases. Now, as mentioned, adrenal insufficiency might be primary or secondary. Primary adrenal insufficiency because it's only ACTH involved. Cortisol will be deficient, but normal axis. Low ACTH will not cause any pigmentation. But when we come to the receptor problems such as MC2R, MRAP, or AAA, there will be pigmentation. Again, because only ACTH is involved, there will be normal potassium. The most dangerous and the most severe ones will be the primary adrenal insufficiency, which might occur in the hemorrhage, infiltration, and most commonly CAH. In these cases, there will be pigmentation, and the sodium loss will be much more in severity and will be associated with hyperkalemia. Now, salt wasting CH, the most common cause of primary adrenal insufficiency in children. Of course, there are various types, but most commonly 21 hydroxylase deficiency is something which should be looked out for. Now, according to where the defect is, such as Smith-Lemli opiates, look for 7 DHC levels. Star SCC will have low distal metabolites. 21 hydroxylase, we all know, is 17 OHP levels. So, according to whatever defect, salt wasting will be occurring in these defects. Now, coming to decreased aldosterone levels and more commonly pseudohypoaldosteronism. Pseudohypoaldosteronism basically caused due to either the mineralocorticoid receptor defect, which might be a slightly less severe disease, but a more severe disease might be caused by the autosomal recessive problem, that is the ENaC defect. There might be systemic involvement, and transient causes include UTI, obstruction, and these are reversible. So what we need to know in decreased aldosterone levels, basically, because of decreased aldosterone, the sodium will be lost and potassium and hydrogen will be retained. So this might cause temporary hyperkalemia, high aldosterone levels in that condition. So these are the various causes of PHA, which I just mentioned previously. So now Bartter syndrome. Bartter syndrome is another important cause. What really is happening here is basically in the ascending loop of Henle, we have a defect in the sodium potassium 2-CC. Now this basically causes increased sodium, increased sodium in the distal tubules in the collecting duct. Now because there is increased sodium in the collecting duct, what really happens here is that all the positive ions, there is increased exchange causing positive ions such as hydrogen and potassium to go into the tubules, associated with calcium and magnesium also in the tubules. So what we are seeing here is hypokalemia, alkalosis, hypercalciuria, hypermagnesiuria, and low calcium and magnesium. Similarly, in Gentleman syndrome, where we have a defect in the NACC defect, again, increased sodium in the tubules, causing loss of potassium and hydrogen. So again, hypokalemic alkalosis. But one thing to differentiate here, we do not have hypercalciuria, but we do have hypomagnesemia and hypermagnesiuria, like the previous syndrome. Cerebral salt wasting syndrome, again, this is a highly debated topic, whether it is actually an entity or not an entity, but most of the studies and most of the evidence is going towards it being a separate entity. Now, it may be caused by various conditions, mostly seen in head injury, such as subarachnoid hemorrhages or brain tumors, causing either decreased sympathetic effect, leading to decreased renin, or more importantly, all the natriuretic peptides which cause sodium loss. The biochemical picture might be very similar to SIDH, which causes a problem initially, but how to differentiate it is usually hypovolemic. Urinary sodium is high, like in SIDH, but differentiating this from SIDH, urinary sodium will be very high, and urine osmolality will be increased accordingly. Urea might also be a very good differentiating factor.
Thanks.
Yes.
Thanks, Pratik, for a wonderful summary of the entire etiology. So now our life is much easier. We know about the various aspects of what is the etiology. We know about the overall aspects with regards to the pathophysiology. Now, what we need to do is that you are encountering a patient of hyponatremia. How do you evaluate from that, and how do you manage from that in that perspective? So the key issues on assessment, and this is the etiology, which is the matrix we'll follow, is it really hyponatremia? If it is hyponatremia, is it free water loss or a sodium loss? Finally, what's the cause? And we'll go from there. So if we talk about, is it hyponatremia? The key issue is hyponatremia basically is a low tone situation. If your fluid tone is less, your fluid will go inside the cells. It will cause swelling of the neurons, and that is going to cause acute problems. If there is a rapid fall, you will have features like coma, seizures, and respiratory distress, which is acute severe hyponatremia. If it's a slower rise, slower fall, but its moderate features will be nausea, headache, and confusion. Now, identifying these symptoms is very important, because when we talk about treatment, you would need to know that whether it is acute, severe, or moderate, because the guidelines are different in that perspective. Now, as time passes off, there is extrusion of the osmoles from the cell, which then will basically try to adjust their size. There will be some chronic symptoms like weakness, cognitive disability, instability, vomiting. These will be the features which are there of chronic hyponatremia in that regard. But the problem will happen is that if you have a rapid correction, if your sodium level rises rapidly, and we'll talk about what is the appropriate rise and what is an inappropriate rise later on, you will have a sudden extrusion of fluid. There will be a shrinkage. So something which has gone up, and if your balloon is blown up and it becomes small, you will have destruction of that balloon. You can think of in a similar fashion. This is what results in an osmotic disequilibrium syndrome. So the features of acute features of hyponatremia are because of cell swelling. The chronic features are more like adaptive features, but correction will basically cause cell shrinkage, which can be a huge problem in that perspective, and we need to be very cautious in that regards. This is something which is quite important from that perspective to identify and evaluate. Now, the manifestations of hyponatremia will depend upon two things: the severity and the rate of fall. So generally, up till around 130, you will have no symptoms. Around 115 to 125, you have features of apathy, irritability, and nausea. Headache, drowsiness typically below 120, seizures around 115 and below. But if somebody was at 140 and suddenly becomes 125, will have much more symptoms than somebody who was sitting at 125 for quite some time. So the rate of fall is also very, very important determinant, and this is what determines whether you need to correct it immediately or not, whether a chronic adaptation has happened in that perspective or not. So this is something which you need to be evaluating in that regards. Now, one important group of conditions, particularly in infants, is with regards to salt wasting crisis, in which you have both deficiency of aldosterone as well as cortisol. They will have more dehydration, shock, hyponatremia, hyperkalemia, along with metabolic acidosis and hypochloremia. So then you start thinking of a combined effect. And as Pratik said, if you have isolated ACTH deficiency, mild hyponatremia, no hyperkalemia. If you have aldosterone deficiency, severe hyperkalemia, mild hyponatremia. If you have a combined defect, severe hyponatremia, severe hyperkalemia, and this is what causes salt wasting crisis in that perspective. Now, very important differential of the salt wasting crisis is a renal abnormality, because that will also cause hyponatremia and hyperkalemia. The condition, however, will have a volume which is increased, while in salt wasting crisis, the volume is less. So if you look at hemoglobin, it will be low in renal failure, high in the setting of salt wasting crisis. Uric acid plus minus in renal failure, because it can also cause hyperuricemia, but high in a salt wasting crisis in that perspective. Any local infection, obstructive uropathy, pyelonephritis can also cause a picture, which can also induce a transient resistance to aldosterone, what we know as PHA type 2, which is a transient form in that regards. Now, very importantly, what is hyponatremia? So sodium levels less than 130, I would say, is significant hyponatremia. Otherwise, people talk about 138 and 135, but what we are really talking about is less than 130. Very importantly, if you should always do via venous sampling, if you're doing from the capillary, it may be erroneously high in that regards. Importantly, conditions which are associated with hyperglycemia, hyperlipidemia, and hyperproteinemia will cause falsely low levels of sodium. If you use an ion selective electrode, the lipid and protein problems will be solved, but hyperglycemia will still cause a problem. So in somebody who has hyperglycemia, for every 100 milligram per dl rise in glucose, the sodium comes down by 1.6. So you have to use that in the form of corrected abnormality in that regards and use this formula specifically to get a corrected sodium in that perspective. Now, once we know this is hyponatremia, the second big question is it excess free water or a sodium loss? Now, I already said that everybody, whether you have sodium loss or excess free water, will have a AVP excess. Whether it is a appropriate or an inappropriate is a questionable scenario in that regards. Now, this is important because management will be different. Here you will say fluid restriction. Here, if you do fluid restriction, it may be lethal in that regards. So what really distinguishes the two? The most important parameter is really the volume status in that perspective. So as we discussed, if you have hypervolemia, if you have low uric acid, your hematocrit is low, urinary sodium is low, you're dealing with a free water excess scenario, third space loss. If you are hypovolemic with high uric acid, high hematocrit, and lot of urine sodium, you're dealing with a sodium loss in that scenario. And so basically volume and urine sodium are the key, and uric acid is a surrogate marker of volume. Low uric acid means high volume, high uric acid means low volume in that perspective. Tests, as I discussed, potassium, uric acid, urinary sodium will really give you a diagnosis in that scenario. We would not need aldosterone or further in the initial phase. So we need to go step by step in that regards. Now, what is the cause of hyponatremia? Look at clinical pointers. Pigmentation will indicate adrenal insufficiency. DSD will suggest you 21-hydroxylase deficiency. Micropenis is a pointer of multiple pituitary hormone deficiency. So clinical examination becomes important. Now, I have already said that potassium is an important clue. If you have somebody with hyponatremia with hypokalemia, this is unphysiological. If you have hyponatremia, you expect the potassium to go up. If you have hypokalemia and hyponatremia both, you are losing both of them either through the urine or through the intestine. So look for drug history. Diuretic use will become important. Look at urinary calcium. If the urinary calcium is high, this could be a Bartter syndrome in the absence of diuretic use. If you have hypomagnesemia, you're dealing with Bartter and Gentleman. Of course, diarrhea you have to evaluate in that perspective. Now, this is interesting. If you have hyponatremia with hyperkalemia, what does it mean? There is a problem in either the kidneys or the adrenals in that regards. So look at the fluid status. If the fluid status is more, it's more likely a renal failure. Hypovolemia indicates a RAS defect. If you are or hypervolemic, you look at kidneys, you look at liver functions, you look at cirrhosis, cardiac disease, and other things. If you are hypovolemic, then you start looking at whether your problem is aldosterone deficiency or resistance, and then work up from that perspective. So as I said earlier, the key workup is volume, urinary sodium, potassium, uric acid. That's pretty much enough. Other workup, renin, aldosterone, 17-OHP is not required in a routine cases in most situations. When will it be required? I'll discuss subsequently in that regards. So if we now have a challenge of renal versus adrenal, so if you have hypervolemia, low hemoglobin, high uric acid, and low urine output, this is renal. Hypovolemia, high hemo concentration, high uric acid, high urine output, this is adrenal abnormality. So if you're confusing between renal versus adrenal cause in that regards. What about SIADH? SIADH is an important cause and something which is there for chronic hyponatremia. It is one of the most common causes. Now, we all know that as the plasma osmolality goes up, the urinary osmolality goes up in that scenario. So essentially, below a plasma osmolality less than 280, you hardly have any urinary concentration. This is normal, but if you have inappropriate urinary concentration, dilute blood concentrated urine, that is what is syndrome of inappropriate ADH secretion. If we talk more in perspective of actual numbers, if your serum is dilute, sodium is less than 135 and osmolality is less than 275, urine osmolality is more than 100 or urinary sodium is more than 25, you have SIADH. But remember, SIADH is a diagnosis of exclusion. If somebody has an adrenal problem, a renal problem, a thyroid or a liver problem, they may also have falsely diagnosis of SIADH. So all this have to be excluded before you diagnose SIADH. Very importantly, if there is hypovolemia, this curve shifts to the left. So in that scenario, again, you will falsely diagnose SIADH. So you should have a clear-cut absence of history of diuretic use or hypovolemia. So dilute blood, concentrated urine, normal adrenal, thyroid, liver, kidney, no diuretic use, no hypovolemia. That's what is SIADH for you in that regard. This is very important because in the first case we showed that if you do fluid restriction in somebody who has a adrenal problem, that may cause more issues rather than any benefit in that regards. Now, very important, if you want to make it more sure, if you give saline, there will be no benefit. And I already talked. The reason for that is that there is a high ANP and there is a low level of aldosterone. So as soon as you give any sodium, it loses in the urine. No point, that's not going to give any benefit in that regards. Now, often this is confusing whether it is SIADH versus cerebral salt wasting. You have a neurosurgical patient, somebody who has a CNS infection, a head trauma, you have hyponatremia, whether it's SIADH or cerebral salt wasting. Theoretically, very easy. SIADH is low urine output, cerebral salt wasting is high output, but often it may be confusing. So what is important is volume. If it's U or hypervolemic with hemodilution, and very importantly, uric acid below typically around 2 milligram per DL, that's more like a SIADH. While if you have hypovolemia, hemo concentration, high uric acid around 6 to 8, start thinking of cerebral salt wasting in that perspective. Very importantly, urinary sodium will be high in SIADH, but it will be much, much higher in cerebral salt wasting. Why is it important to differentiate between the two? Because SIADH management is fluid restriction. Salt wasting management is basically giving more fluids and sodium chloride. So this is very important in that regards. Now, if I summarize all the conditions and which tests will help us make the diagnosis, uric acid will be high in all unless the fluid is more in the setting of fluid overload or SIADH, where it will be low. Urinary sodium will be low if you have fluid overload, which is third space, or there is extrarenal loss. Otherwise, the urinary sodium will be high. Potassium, anybody with hyponatremia, with hypokalemia, think of a GI loss or a tubulopathy. Anybody with hyponatremia or hyperkalemia, think of a renal problem or a RAS defect. And hemoglobin, as I said, if it's high, it's hemoconcentration. Think of a diuretic use or fluid loss in that regards. One very specific situation is the situation of a neonate who presents to you with salt wasting. Again, here the gender, the genitalia will give you a diagnosis. So if you have somebody who has XX-DSD, large adrenal, this is 21 hydroxylase, most common in that scenario. If you have abnormal genitalia, both XS and XY, this could be the rare 3-beta HSD and POR forms. If you have a XY DSD, it can be star defect with a large adrenal. On the other hand, if you have normal genitalia in a male with small adrenal, that will be adrenal hypoplasia congenita. While if everything is normal, this could be pseudo hypoaldosteronism. So genitalia, adrenal size and aldosterone levels, aldosterone will come later, will give you a diagnosis in neonates who present you with salt wasting, because that could be a life-threatening scenario in that regards. So now whatever we have talked, we'll summarize into 2 slides about approach. The initial approach is to do basic things, exclude pseudo-hyponatremia, hyperglycemia, hyperlipidemia, hyperproteinemia, and renal failure. If all that is normal, look at volume status. If the volume status is more, we are dealing with third space loss, cardiac failure, liver disease, renal failure. If the volume is normal, look at thyroid and cortisol. If it is normal, this is SIADH. If it's abnormal, that's like a multiple pituitary hormone deficiency. If volume is low, look at urinary sodium. If the urinary sodium is low, this is gastrointestinal loss or rarely cystic fibrosis. If it's more, look at potassium. If potassium is low, it's tubulopathy and diuretic use. While if potassium is high, it's RAS defect, get in renin and aldosterone defect done. That will tell you the diagnosis. So as I said, if you look at volume, urinary sodium and potassium, 95% of your differentials are done. You don't need to do very many investigations in that scenario. Now, this is interesting. If you have a neonate who comes to you with salt wasting, first of all, exclude an infection or obstruction. Look at genitalia. if there is a usual genitalia with a palpable gonad, which basically would mean that there's no palpable gonad, you're dealing with a XX-DSD. This is clearly going towards 21 hydroxylase deficiency. If 17-OHP is very high, this is 21 hydroxylase. If it's borderline, this could be 3 beta or 11. If, however, you have got no palpable gonad, it will indicate the possibility of a XY-DSD with a salt wasting. Look at DHEAS. If your DHEAS is low, this is a proximal defect, as Pratik was talking about. If it's high, this is like a 3 beta hydroxysteroidehydrogenase deficiency. If your genitalia is normal and you have a male, you look at 17-OHP because CH will often be missed. If it's high, this is 21 hydroxylase. If it's normal, do imaging. And if imaging shows small adrenals, that is adrenal hypoplasia congenita. If it is large, then you start talking about other things which we'll discuss subsequently. In females, 17-OHP low suggests star defect. But if 17-OHP is normal, then you go for aldosterone levels. If aldosterone is low, there is aldosterone synthesis problem. And if it's high, it is pseudo-hypoaldosteronism. So from a neonatal perspective, I've given importance to genitalia, 17-OHP. This is pretty much what is required. If you have abnormal genitalia in a XX, it's typically 21 hydroxylase deficiency, rarely 11 and 3 beta. If it's a XY-DSD, then start thinking of rarer proximal defects. If genitalia is normal in a male, rule out 21 hydroxylase deficiency and then adrenal hypoplasia congenita. In a female, do 17-OHP. If everything is normal, look at renin and aldosterone. If renin and aldosterone is also high, that is pseudo-hypoaldosteronism. If aldosterone is low, that will be a synthase defect. So renin and aldosterone do not do right here. Do it at the end if everything else is normal. That is the crux of this whole presentation, to really make a very practical and a cost-effective approach in that regards. So now we'll run through a few cases. 12-year-old boy with DKA, high blood sugars, and what we found was that the sodium is 126. Now, this is classically abnormality, which is pseudo-hyponatremia. So for every 100 milligram per DL rise, we have to add 1.6. So we have to correct this sodium, and what we found, it comes as 135.6. So in a DKA, always correct the sodium. That becomes important. 3-week-old child with failure to thrive and severe hyponatremia. Now, if you have a severe hyponatremia, I can bet it's a combined glucoaminocorticoid deficiency. There is a failure to thrive, dehydration, high PCV, again suggesting adrenal salt wasting. Now, what we found here was there was a high urinary sodium and the potassium was high. And when we looked at the genitalia, it classically showed atypical genitalia. So this is a newborn who has a XX-DSD with a hyponatremia, hyperkalemia. This is a classical presentation of 21 hydroxylase deficiency. Not much of a doubt in that regard. 1-week boy with seizures, hyponatremia, and hypokalemia or a normokalemia. This is important because now people will say this cannot be adrenal insufficiency, but I'll correct that this can be a central deficiency, ACTH deficiency. There's no dehydration. Fluid status is normal. Blood sugar is also low. So there is hypoglycemia and hyponatremia. I think the clue is already there. On examination, there is micropenis. So this is classically a case of multiple pituitary hormone deficiency. Importantly, cortisol of 125 may be reported as normal. Growth hormone of 4 may be reported as normal, but they are inappropriately low for the level of glucose, for the level of sodium. So this is classically a multiple pituitary hormone deficiency. So always think of MPHD in this scenario. In this case, already we've discussed how a child with a central defect was diagnosed as SIADH. So whenever you are diagnosing SIADH, do a thyroid profile and do a cortisol before you make a diagnosis in that scenario. Now we have an 11-year-old boy with traumatic brain injury, admitted in the ICU, improved with management, now developed seizures. There is hyponatremia. The urinary osmolality is on the higher side. So what do we do? Now this could be SIADH or cerebral salt wasting. The most important investigation is uric acid, and uric acid here is low. So this will go more in favor of an increased volume and SIADH in that regard. So I would say uric acid is a very, very useful test in anybody who has a neuro surgical or a CNS related hyponatremia to distinguish between SIADH and salt wasting. This again is a case which we highlighted, a 16-year-old girl with abdominal pain, diagnosed with SIADH, but very importantly, you have to look at the cause, what caused SIADH, and that turned out to be porphyria. So you have to go beyond just making the diagnosis in that regard. So now we have discussed about the pathophysiology, about the etiology, about the approach, and now we'll go on to management, because that's also very, very important in that perspective. So the key principles of management are that do not give emergent treatment unless it's an acute severe form. Very importantly, be careful about rate of correction. In severe cases, you can go up to 12 because there the osmoles have not been extruded. In moderate cases, 6 to 9. Chronic cases, less than 6. Very importantly, underlying condition also needs to be treated. So if you have SIADH and fluid overload, do a fluid restriction. Hypovolemia, you will give normal saline in that regard. So this is something which you have to be very, very careful. If you are able to correct it orally, give it orally. Usually if you're giving IV, the typical sodium is around 70 to 100, and 120% is what is required in that regards. So the acute treatment will depend upon the duration and the symptoms. Now, often you may not know the duration. So we have put that also as a caveat. If the duration is less than 48 hours, child was fine 48 hours ago and suddenly there's a problem and the symptoms are severe, sodium is less than 120, coma, seizures, this is an emergency. You have to do everything to salvage the child. So you give 3 to 5 ml per kg of 3% saline and rise by 9 to 12 millimoles per liter per day. If you have mild to moderate symptoms, sodium 120 to 130, headache, confusion, you will give small push 1 to 2 ml per kg of 3% saline, rise of 8 to 9 millimoles per liter per day. If your duration is more than 48 hours or it is unknown, then you assume it to be chronic in that regards. Still, if you have severe symptoms like severe hyponatremia, coma, and seizures, you will correct it using 3% saline, but rise will be lower, 6 to 8 millimoles per liter per day. If it's mild to moderate, you have nausea and other features, don't give 3% saline, you correct, rise it by 6 to 8 millimoles per liter per day. So very importantly, acute severe, acute moderate, give some 3% saline, but rise has to be slow. Chronic, the rise has to be absolutely low in that regards. Now, often we have to answer about how do you manage hyponatremic dehydration. There are various ways to do that. We have put forward a simplified way. You look at how much is the fluid deficit based upon dehydration level, which will basically be 0.6 into weight minus deficit will be your estimated body water. Then you calculate the hyponatremic sodium deficit, which is estimated body water into 135 minus sodium. Isotonic sodium deficit, which is fluid deficit, into 140. Then you will know the maintenance, of course, which is 4 to 1 or 150-20 formula, sodium of 2 to 4 millimoles per kg. Then you correct and deduct the bolus fluid volume and bolus fluid prurium, and you get the final fluid in terms of volume and tonicity. So very importantly, you calculate the fluid deficit, the sodium deficit, which is hyponatremic and isotonic, and then you correct it over to avoid a rapid correction in that regards. Whatever calculation you do, you need to have close monitoring, reduce rate if there is a rapid rise, relower if there is a symptomatic scenario in that regards. A word about SIADH. Now, the problem here is that your fluid should be restricted, 60% of maintenance, 1 to 2 millimoles per liter per day. If you give sodium chloride, you will actually lose the water in that regards because ANP is high, aldosterone is low. So sodium chloride is not going to be a solution. If you want to give something, give 3% saline, which is actually a osmolar diuresis. So that's why we use plain NS. 0.9% is not going to make any benefit in that scenario. What about vaptins, which are V2 receptor antagonists like tolvaptan, conivaptan? They are not recommended in acute hyponatremia in children. You will have a rapid rise and there will be a lot of problems which will be happening. So don't use vaptins in the acute state. You can think of in chronic state in that perspective, and that's important. In certain situations, you can induce a DI-like picture using lithium or demiclocycline or urea in that scenario. So we have a 13-year-old girl with drowsiness and hyponatremia. Urinary osmolality is on the higher side. SIADH was diagnosed and tolvaptan was given. Now, this is important. As I said, don't use these agents because they will cause rapid increase, and this will cause what is known as osmotic disequilibrium syndrome, the manifestations of which will be later. You won't have an acute manifestation. This is a very, very problematic scenario. 16 hours later, abnormal speech and vacant stare. So this is a rapid rise. So osmotic disequilibrium syndrome is a very dangerous situation, typically happens with severe hyponatremia, rapid correction, and there would be a time phase. It is not an acute phenomena. You will see it after 24, 48 hours. It's all because of the osmosis, and you cause rapid correction. Your balloon goes up and then it comes down. It will shrink and it will get damaged. That's what is very important from that regard. So if you have anybody who has a chronic hyponatremia, fluid changes, look at the eyes for the pupils, whether they are constricted, look at speech defect, look at other parameters, because that's something which is very important in that regard. So what do? We can think of a salvage therapy. So this is what you want, the sodium to gradually rise. But if you have given Vaptan, and as in this case, sudden rise, what you need to do is to do a relowering. So you can do here either give a desmopressin, vasopressin, or free water to decrease it. So if you track it properly, and you know that the rise is more than 9 to 12 in acute severe, 6 to 9 in acute moderate, you give more free water to bring it down. This is very, very important. Otherwise, the patient will go into osmotic disequilibrium syndrome in that regard. So 9-year-old girl with CLD, sodium is 115, anasarca, drowsiness. Now here 3% saline was given. This is not really recommended because this drowsiness could be because of hepatic encephalopathy. She may have chronic hyponatremia. So no point of doing that, and you will have severe problems in that regard. So if your duration is above 48 hours, generally do not give 3% saline. That's the big message in that perspective. What about this girl? 18-year-old girl be diagnosed with AIP, has headache. This is acute hyponatremia. There is headache. So in this scenario, we can not give, we don't need to give 3% saline, but we can give correction and fluid restriction, which is there. But if you have severe abnormalities, seizures, and anisocoria, like this person with head injury, you have severe hyponatremia, high urinary sodium. So this is more like a cerebral salt wasting. Here, there is severe symptom. You give 3% saline and seizures will be controlled. So give 3% saline if you have an acute severe or an acute moderate effect. What about specific management? Think of if there is a fluid overload, correct the cause and do fluid restriction. SIADH, fluid restriction and VT receptor antagonist, not in the acute phase. Adrenal insufficiency, give hydrocortisone and fludrocortisone. And in PHA, give sodium chloride and furosemide in that perspective. In Bartter syndrome, you can use indomethacin and amiloride. So now we will head towards the Q&A, and Dr. Manoj and Dr. Pratik will carry forward with regards to the question and answer. So over to you.
Thank you, sir, for such a wonderful and extensive discussion about hyponatremia. That what is hyponatremia, how to manage, and what lab investigation is required. So now for the any PG and for the any DNB, how to write in exam, that is the most important thing. So now in next session we will discuss about the questions answer. So we will move towards our next session.
Dr. Pratik, you can upload.
So first question, what is hyponatremia and what are the etiology for hyponatremia? Over to Dr. Pratik.
Yes, so this is a very important question. In fact, one of the most basic questions, and sir has very well explained the condition. So more or less, if at the time of exam, if you're not remembering, just remember hyponatremia can be caused only either by if there's increase of water in the body or the sodium is being lost from anywhere, urine or row. So, and the free water can be actual increased water or reduced loss. So if we just remember the top part of it, the answers will just come to us. And remember the concept behind urine sodium rather than just mugging it up. Urinary sodium will be low in cases of any fluid, any decreased fluid, whether it be euvolemic or actual hypovolemic. The body is considering that there is low volume. So urinary sodium, excess free water, and or sodium loss. Just the basic things you remember, then the next flowchart will come following. Again, what is hyponatremia? 130 to 135, but actual problems start at less than 130. The site is very important. You take venous more than capillary, around 2 to 3 differences there. And what causes such as pseudo hyponatremia due to lipids or protein or the glucose level, these are also important factors. Okay, the basic next question is.
So now we.
Good.
So now we will move towards our second question. So what are the clinical features of hyponatremia and what lab diagnosis is required for hyponatremia?
Yeah, another very important question. So again, hyponatremia, it depends on when the child has presented, what is the sodium level. But the most important bit is what was the rate of fall. That is much more important than the absolute level. So as and when many patients must have, students must have seen many patients that acute hyponatremia can be either severe or moderate. So acute means there is coma, seizures, whereas moderate can actually sometimes come to the OPD also with nausea, headache. But chronic symptoms, which is actually most common in the OPD, can be weakness, cognitive defect without any cause. And you do a sodium, it comes low. So at that time, treatment should be well thought of. If it is acute severe, give the 3% NaCl. In chronic, be very careful because it lead to ODS and shell shrinkage can occur. Again, this is a very important and very nicely laid slide. The symptoms worsen as the sodium levels drop. So the rightmost basically is around 130 to 135. In the middle, where you see headache, drowsiness, apathy, irritability, nausea, can be between 120 to 130. And of course, less than 120, expect seizures and raised ICP. But be very careful. If it is a chronic, a very low sodium can come walking into the OPD. So that has to be kept in mind. So treat according to the symptoms, treat according to the duration, and look into these factors before just giving immediate treatment at that time. So the next is basically if you have a salt wasting crisis. Now, how is this different from just plain simple hyponatremia? The level of dehydration will be much more severe than say just a hyponatremia. The child might be associated with shock. Now, the hyponatremia in this case, it will be much more severe. Usually, if it is only sodium associated, usually it lies between 120 to 130 or maximum 125. But in cases you will see even less than 120 might occur with cases of salt wasting. It will be associated with hyperkalemia, metabolic acidosis, and the differential of this basically will be renal failure, obstructive uropathy, and pyelonephritis.
So it was a very nice explanation about various clinical features of hyponatremia. So important thing, level of sodium and level of fall is also important. So we will move towards the third question. What are the types of hyponatremia and what is the difference between SIADH and cerebral salt wasting syndrome?
Okay, so these two things have been very well discussed. Just remember, in a sick child, you can have both, especially when there has been a cranial or a head injury. Hyponatremia can occur in both. So both will have urinary sodium more than 25. Both can have hyponatremia. But what you need to remember is in SIDH, the child will be euvolemic. So uric acid might help to differentiate between the two. And one more thing is polyuria might occur in salt wasting syndrome. And another differentiating factor is that in cerebral salt wasting syndrome, the urinary sodium will be very high. It won't just remain between 20 to 30, it will be very high, up almost about 100. So that is one differentiating factor which might be important. So if we look at the two things, the differences between the two is very well shown in this table. Cerebral salt wasting syndrome will have features of hypovolemia such as high hemoglobin, hemoconcentration, uric acid may be high, urine output will be high, and urinary sodium will be much higher. But these are the things which you must remember. In practically, it might be slightly difficult, but these points might help us decide.
So now we will move towards the management part. So what are the management for the hyponatremia and how to manage specific condition of hypovolemic hyponatremia?
So, as Sir very well mentioned, emergent treatment is only in acute severe, because rate of correction in acute severe, any acute severe has to be treated with 3% NaCl, and then concurrently the rate of increase in acute severe should be less than 12, acute moderate between 6 to 9, and chronic less than 6. Because after correction, you might get a false sense of security that child is fine, but only after 48 hours when the child develops symptoms, it might be very drastic. So please correct accordingly. Now, in especially chronic diseases, just treating the underlying condition will lead to improvement, and you do not need to give 3% NaCl. So in SIDH, fluid overload, give fluid restriction. In hypovolemia, just normal saline. Of course, oral is preferred. Give 120 to 140% maintenance. So this slide very well shows and is a very well depicting slide showing basically based on the duration and the symptoms. So the duration is less than 48 hours. If there are symptoms, you have to treat. If there are mild to moderate symptoms, sodium between 120 and 130, you may not give 3 to 5 ml, but 1 to 2 ml per kg. And the rise should be between 8 to 9. If the duration is unknown, consider it as chronic above 48 hours. If there are symptoms, only when there are symptoms, then you give. If there are no symptoms, do not give 3% NaCl. Treat the underlying cause and it will improve automatically.
So I think that was a wonderful discussion on part of both Dr. Manoj and Pratik, who really summarize the entirety of our talk. What we'll do now is that we'll take some questions if they are there, and then we'll close this session, and we'll be uploading the videos also subsequently. Dr. Linda is talking about what is about a case of very low sodium and normal potassium. This is an unusual scenario, and generally speaking, I have seen a couple of cases with severe MPHD who can present like that. Sometimes you can have severe SIADH because of a nephrogenic SIADH which can cause, but this is an unusual scenario. If you talk about sodium levels less than 110 or 120, that will be unusual. Usually 120 is okay. Less than 115, that becomes difficult. Dr. Rajiv Das is asking what would be the initial food in a 6-year-old child with body weight 20 kg admitted involved with Japanese encephalitis so that hyponatremia can be prevented. So generally, more people are more talking about in terms of more fluids which is appropriate, more physiological rather than the hypoosmolar foods. So Dr. Pratik, what will be your take on somebody who has a JE?
Sir, initially we are at a risk of developing hyponatremia. So more than the fluid, it is the regular monitoring of the fluid which we should do. Of course, normal saline, we can see whether how the sodium is dropping or rising more than what exact fluid we are giving. That
generally, we should look at the maintenance fluid, whatever is recommended for anybody else. There is no routine recommendation to restrict fluids in that setting or to really look at different fluids. You monitor the sodium. That is more important because it may not develop in many cases. You will have normal, and then giving less fluid may be a problematic scenario. Dr. Rajiv is also asking about volume status in kwashiorkor. That's again an interesting scenario. So then uric acid may be a role in that perspective that will give you a picture in that regards. It will behave more like a fluid third space loss scenario. So more like a CCF or a liver disease or nephrotic syndrome. Dr. Ashubu is asking when looking at rate of fall, what should be the interval between the requests? So generally speaking, that will depend upon the severity. I would say 3 to 4 hourly will be reasonable in that regards. If you're giving an infusion, then you have to be more careful, but 3 to 4 hourly is good enough. Dr. Subhash is asking low sodium, low potassium. The most common cause I would say would be diuretic use. That's what we encounter less in children, more in adults, but that's the most important cause. Rarely diarrhea with inappropriate ORS will be the second scenario. The third would of course be tubulopathies, but diuretic use number one would be that in that scenario. So I think we had an extensive discussion about hyponatremia. I'd like to thank Dr. Manoj, Dr. Pratik for this wonderful discussion and thank all of you for joining from across the globe. We will have the next session next month on hypernatremia. So this session is now on electrolytes. So hyponatremia, hyperkalemia, renal tubular acidosis, and CAH. This is the way we'll carry it forward from that from here. Thanks all of you for patient hearing. Thank you.